Thank you. Thanks. This is really fun. This is like a family reunion for me. I don't know the last time I got to speak in this school in the company of other historians. So wow, this is fun. Look, I wanted to talk about a couple of things, and I'm going to issue a pair of challenges in conclusion, so be prepared. One of these is external about the way we in public health relate to the rest of the world, and the other is internal about how we relate to ourselves and how we can improve. And as Ingrid said, I'm going to talk a little bit about the development of public health infrastructure and the role of infectious disease in provoking that. If there's one top-level conclusion from recent disease outbreaks, such as Ebola in West Africa or Zika in Central and South America, it's that the world has bifurcated into functioning health systems and ones that don't work well. In our Department of Global Health and Population, we're most concerned with the ones that don't work well, and that's a mandate shared by the rest of the school.
Thank you.
And the question is, how did we come to this bifurcation?
Thank you.
I'm going to talk about the formation of some of the functioning systems. And both of the two primary ways we finance healthcare are tied to this. So from Bismarck and social health insurance in the dawn of modern Germany, when it was unified in the 1870s, that's one model, and the launch of the welfare state by the British around the Beveridge model of tax financing, it shows you how closely connected public health is with the core of the modern state. The core of the modern state is built around the protection and advancement of public health. That's a very special role that public health has. And this dynamic between states and citizens, or what we call the social contract that defines modern states, adjudicates how and when it grows. Often that window of growth opens during an infectious disease opportunity. So I'll tell you a little history to show you something about how this opens and how capacities are built. There have been 7 cholera pandemics in history. The first of these was 1817 to 1824, and the most recent, the 7th, was from 1961 to 1975. By the 4th of these, some interesting things happened. Alan reviewed some of the history of New York City, so I'll talk about London. In that 4th pandemic, the cities and the government, they decided to do something about it. 3 of the pandemics had swept London with massive mortality. They decided to prepare in between the 3rd and the 4th. And what happened is the template for modern city government. The title of mayor, which is an older historic title, was reused for this urban position of authority where that office holder would be served by a city council with eminent domain, so could seize land and could levy taxes, and citizens had electoral and tax-paying responsibilities. All of these mechanisms have been copied by every urban administration in the world, and in this case, it's designed for sewerage. That's how you build a sewer. You assign responsibility for it, you promise benefits to citizens, you give the government some control, you make citizens pay taxes, and they elect a city council. It's the most direct form of democracy. That's what gets citizen participation. This is the template for all of urban government, and this is the dawn of urban services. Shortly thereafter, water filtration was brought in as an urban service. Previously, that had been privately supplied. This is the template that has now spread around the world. So any mayor's office in this country, any mayor's office practically anywhere, is set up and organized the same way. They don't all work as equally well against cholera, but in a state of organic and autonomous development in the English state, you can see what happens under the stimulus of cholera. As Alan was mentioning in New York City, this massive shared threat fosters collaboration between state and citizen that then develops a set of capacities institutionalized for responding. They can weaken over time, but largely this is an accumulative story. So another story like that that relates to us here at the school is in 1798, the U.S. Act for Relief of Sick and Disabled Seamen established its first hospital, the Marine Hospital in Boston. Baltimore was second. These were hospitals designed to deal with infectious diseases related to commerce, which were frequently carried by sailors and other people associated with marine trade. In 1887, on Staten Island, reflecting the Marine Hospital Service's evolving role in screening immigrants for disease, they opened the first bacteriology lab. The bacteriology lab, located on Staten Island, added the scientific dimension to screening diseases of immigrants. That bacteriology lab had two consequences for us. The first is the lab grew, it broadened, eventually moved to Bethesda in 1930, was renamed the National Institutes of Health. The second is that the second director of that laboratory from 1889 to 1909 was Milton Rosenau. In 1909, he joined the Harvard Medical School and was instrumental first in establishing the joint project with MIT, our School for Health Officers, and then particularly in 1922 was instrumental in evicting MIT and establishing the Harvard School for Public Health around the bacteriology model that he had pioneered in the Marine Hospital Laboratory. He also, in 1936, founded the program at UNC, which quickly became their School of Public Health a few years later. And a related issue would be the CDC. Anyone know where the CDC comes from? So the CDC was the Malaria Control in War Areas program in World War II. These are three quick examples to show you what happens when states and citizens collaborate around infectious diseases. Some of our most important national institutions in which we can elevate ourselves if we want, but also CDC and NIH are founded around this common threat of infectious diseases and the development of capacities to manage them. Managing them both in research capacities, in implementation capacities, programmatic capacities, and for us in training and research. This leads me to ask the two questions. The first is the external question of how we as a profession of public health engage the wider world. If, as I said at the beginning, there are two kinds of health systems and one very large group doesn't work at all, what are we doing as a profession to strengthen this state-citizen contract that builds capacity? Most of what we're doing probably doesn't relate that well, and I'm arguing that it should. The second thing I want to ask you is an internal challenge, which is how are we as a profession and as a school learning from our own heritage? How are we engaging our history and learning from our own encounters of infectious diseases and programmatic experiences to build the knowledge and capacity we need to succeed in the 21st century? Thank you.